Hi, everyone. Thank you so much to the CLL Society for inviting me today. And thank you to all of the patients with CLL, their families, friends, and caregivers for joining us today. And for the last structured presentation of the day, I'll be reviewing the data we have available for COVID-19 in CLL patients. And obviously, the COVID-19 pandemic has radically shaped 2020 and impacted every aspect of our lives. So the data here are only a few weeks old, but as of this morning, there have been almost 37 million cases of COVID-19 confirmed and over 1 million deaths worldwide, with 200,860 deaths in the United States. And our understanding of this pandemic is rapidly evolving as more data become available. So the data I present today as of today, but I also want to stress that this is a quickly moving field and recommendations are ever evolving. So you've probably heard that the elderly, people with pre-existing medical conditions, and people with compromised immune systems are at increased risk of COVID-19. And the thought is that these patients are both at increased risk of contracting COVID-19 and also at increased risk of bad outcomes if they do get COVID-19. And there have been lots of series to support these claims in patients both with and without cancer, including the early studies from China and subsequent big series from the US and from Europe. And many of these studies have demonstrated that patients with cancer are at particular risk, both of catching the virus, but also of their course if they do get it. And I've included on this slide just a few snapshots of those data. So on the left, you see graphs depicting mortality rate for patients with cancer who get COVID-19. This shows that patients with all types of cancer, and particularly those with blood cancer that are marked by pink and red bars, as well as those undergoing treatment for cancer, have unfortunately high mortality rates when they get COVID-19. The graph on the right demonstrates that age is associated with higher mortality rates, so that older cancer patients are at greater risk than younger cancer patients if they contract COVID-19. But obviously, there are many types of cancer and that are probably associated with different risks. So we want to think more specifically about CLL. And the first question that I want to address is the question of incidence, meaning the proportion of people with CLL getting COVID-19 when compared to the proportion of people getting COVID-19 who do not have CLL. Published from the UK compared big groups of people with blood cancers, including all types of leukemia, all types of lymphoma, and multiple myeloma, to people without any cancer diagnosis. And they found that the incidence, or the number of COVID cases that were diagnosed within the group of patients with blood cancers, was higher than in the group of people who had no cancer. But incidence in CLL patients specifically is unknown. We think that patients with CLL might be particularly at risk for getting COVID-19, given that CLL is more commonly diagnosed in people who are older, and we consider patients with CLL to be immunocompromised, both from their underlying disease from the CLL cells, as well as from the treatment for CLL. However, we don't have any high-quality studies available right now to help us understand how frequently people with CLL are getting COVID-19 and how that compares to people without CLL. So this is a huge question and researchers are still working to answer. Next, we'll shift gears to understanding how patients with CLL do when they get COVID-19. And to answer this question, we have two large studies, each with about 200 patients that describe COVID-19 outcomes in patients with CLL who were diagnosed. Now, these studies both looked at patients diagnosed in the spring. So I'll remind you that back then, we were really only testing patients with symptoms. And as a consequence, these studies likely did not capture patients who were asymptomatic or only mildly symptomatic and stayed home. And as such, I want you to keep in mind that these data apply to a group of patients who were ill with COVID-19, not necessarily to all CLL patients who get COVID-19. So these tables are from the two papers that I described, and they describe the symptoms that patients experience when they have COVID-19. So the most common symptoms noticed were fever, cough, shortness of breath, muscle pains and joint pains, diarrhea, and fatigue. And these studies suggest that for patients with CLL who develop symptomatic COVID-19, this is a very serious problem. In both studies, the fatality rate ranged from 30 to 35%, so a very significant problem. These papers have found that patients who are older and have other medical problems, such as asthma or chronic kidney disease, or patients who were concurrently smoking cigarettes, were particularly at risk. And one study suggested that treatment for CLL was actually associated with better outcomes, though that wasn't found in the other study. So that's still an area of debate. Interestingly, BTK inhibitors like ibrutinib and acalabrutinib that you've heard work through different pathways that might actually be protective against severe manifestations of COVID-19. And there are ongoing clinical trials of BTK inhibitors in patients who get COVID-19 but do not have CLL. So there's some thought that this might be protective, though obviously that's a hypothesis until we have data from the clinical trials. And finally, it's worthwhile to consider how patients with CLL will respond from an immune standpoint when exposed to the infection. And a normal immune response to an infection is to make antibodies. And those antibodies are designed to protect us from future infections. So some early studies suggested that patients without cancer who have COVID at a very high rate produce these antibodies. We did this study where we looked at a small set of patients with CLL who had documented COVID infections, and we checked if they'd these. And we found that the rate of antibody production was much lower than comparative studies of patients without cancer. Now, these data might have implications on our ability to mount an immune response to vaccines, should one be developed and approved. And this isn't totally surprising, since we know that patients with CLL do not always mount robust responses to other vaccines, as you just heard. However, I want to emphasize that we're still not sure about the implications of these data or how patients will be affected by this. There are many different pathways through the immune system, and T cells might also be involved in protecting us from COVID-19. So the absence of antibodies doesn't necessarily mean that a patient wouldn't be able to respond to a future infection. The other important topic that you've likely heard about is herd immunity, which means that infections are less likely to spread through communities if an adequate number of people are protected from those infections. So if there is an approved vaccine and it doesn't provide robust protection for patients with CLL, protections of those around them would also add some degree of protection for the patient. And finally, I wanted to touch on the effect that COVID-19 has had on the management of CLL. Many sets of recommendations have been made from groups of CLL experts, and specifically, the COVID-19 pandemic may affect how your doctor thinks about when you need to be treated and with what to treat you. There's been some shift toward more pill-based therapies and less exposure to the medical system. So it's worth having a discussion with your doctor about kind of optimizing the approach to therapy right now. There are also probably changes that you've noticed in terms of logistics of clinic visits. So with the advent of telehealth and the increasing use of telehealth, you may have experienced that and know that doctors are trying to protect you from having to come into offices frequently. In terms of when to test for COVID-19, obviously for patients who are symptomatic, having fevers or any of the symptoms we described, getting tested is a good idea so that your doctor can be vigilant about monitoring you and ensuring that you're getting appropriate care. But you may also be tested in advance of hospitalizations or planned procedures. And then changes in therapy if you do happen to get COVID-19. In many cases, CLL-directed therapy is continuing despite COVID-19, though depending on how ill a patient is, this may or may not change. And then last, I want to remind everyone that hand washing, social distancing, and mask wearing are the best ways you can protect yourself from COVID-19 and are recommended by the CDC. And with that, thank you for your attention today, and I'll turn it over to Dr. Kaufman, who will join us for audience questions.